brief history of the story of apartheid in this country. Now, these were, signs like this were all over the place, including in our hospitals. One entrance for white people, and the other entrance for non-whites or non-Europeans, as you'll see on this slide. Now, so I worked at a children's hospital during this time. Our hospital, which was linked to the University of Cape Town, had a front entrance for white people and the back entrance for the rest. Now, the thing that used to really bother me about this was, what does it tell you? What does it tell a child? What does it tell children about who they are, about their identities, if they're not allowed to go in through the front, if they have to go in through the back door and be processed in a different way? This is a very fundamental issue about health and our understanding of health. Now, there's one, unfortunately, when the democracy arrived, all the apartheid signs at our hospital were kind of destroyed. But recently I found one in the old hospital switchboard. This is the last kind of remaining sign of apartheid at the Red Cross War Memorial Children's Hospital. As you can see, there's even in the switchboard, there's a switch for non-European outpatient. This is just amazing, and it's still there as far as I know. I haven't been there for a few years. But this is kind of the last remnant. Now, the anti-apartheid struggle in health was essentially a struggle for primary health care. And primary health care, which I'll come on to in a minute, what it all means, but in the 1940s in South Africa, the first kind of glimmerings that health is not about doctoring, not about hospitals, not about the health system itself, but about much more than that. And probably one of the earliest sort of descriptions of the social determinants of health was provided by Sydney and Emily Clark, who worked in the rural areas in KwaZulu-Natal, who developed this idea of a community syndrome, what they call the community syndrome. So they were working in very poor rural area, where the men had been kind of hijacked to go and work on the mines. So they said the community syndrome starts with a migrant labor system, which meant that the men were away from home, loss of skilled farmers, as you can see on this outline, poor agricultural methods, soil erosion, low food production, leading to malnutrition, mental health problems, and so on. I think this is one of the really early kind of expositions of the social determinants of health. In 1978, the idea of health for all became a worldwide goal at the International Conference at Alma-Ata, which is the capital of Kazakhstan. And here health was recognized as a fundamental human right. Now, what does this mean? It's easy to understand maybe that health services, when you talk about universal coverage, that the access to health services can be a human right. But what about health? So what is the right to health? And probably the simplest explanation I heard about of that is that the right to health is the right to enjoy a healthy life. So this came about at the Declaration of Alma-Ata, and this is really the kind of theme for the health struggles in South Africa during apartheid. I'm afraid I'm having to go through this a bit too quickly, but primary health care as the ideal of primary health care, which the key elements of primary health care is to move the idea of health out of the hands of professionals, out of the hands of health facilities, and into communities. And the key elements that are most difficult to implement are community participation, which is threatening to the powerful elites who kind of control, who have hijacked people's health. And it's also threatening to politicians and to big business and so on. That's the first one, is community participation. The second is intersectoral collaboration, getting all the sectors to work together for health so that there's health in all government policies, in all health struggles and so on. So the idea of primary health care proved to be too kind of threatening to the establishment, and it didn't last very long. Very soon after the Alma-Ata Declaration, it was replaced with a set of targeted interventions aimed at treating priority diseases. And this happened in this country too, when the ANC discarded its own health plan, which came out of the idea of primary health care, and also discarded the kind of ticket for the first democratic election, the Reconstruction Development Program, and changed to GEAR, the Growth, Employment and Redistribution. Trevor explained this very well the other day, but essentially in health, what it led to was serious cuts in public spending in the health system, a massive growth in privatization, and as I said, the ANC abandoned its own health plan. It hasn't got a new health plan except for the National Health Insurance, but that's what happened during the transition. So now we're in a situation where if you look at this map, or this graph, countries have plotted health versus wealth, if you like, with health vertical and wealth on the horizontal axis. And as you can see, most countries fall in a kind of a band where as countries get richer, they become healthier. Now, South Africa, as you can see, is an extreme outlier. It's way off this, it's much unhealthier than many countries that are much poorer than we are. Recently, there's been a dramatic improvement. You'll see the little pink arrow there, which points to an increase in life expectancy in the country recently, and this is due to the rollout of antiretrovirals and prevention of mother-to-child transmission of HIV. So there's still too many child deaths in our country, and they're mainly due to neonatal problems, diarrhea and pneumonia. I don't want to spend too much time on this, but what I would like to point out here is the health sector inequities that we've kind of got as a result of these last few years coming on top of the apartheid inequities. And here you can see the difference. For example, the private health sector covers 8 million people at about 11,300 Rand per person, whereas the public sector has 35 million people to look after, with also about 43% of the health expenditure, about 1,900 per person is spent in the public sector. And then there are a few people who use both systems. So these are inequities in the health system. But to get back to health for all, I'm going to have to skip some of this. Sorry, do you mind if I just prioritize this a little bit? Because I'm going to this is so slow. Sorry. I can't read. Okay, I'm going to skip through a few things and talk about why the health system is not, why good doctoring and good health systems are not enough, and universal coverage is not enough to ensure health. This slide shows you the annual diarrhea tsunamis that we have in Cape Town. During December, February, April, up to about June, there's a diarrhea epidemic. And it is located in certain areas around Cape Town, Khayelitsha. When you go on your site visit, you'll probably see where the most cases of diarrhea occur. Those are the spots. But the diarrhea deaths have diminished, although the numbers have gone up. And the question is why? It's because the health department has instituted measures to recognize diarrhea earlier and to treat it earlier. But overall, the overall mortality of children in the Western Cape has not really decreased despite better doctoring and better health facilities. So good pediatrics and a good health system is just not enough because it doesn't deal with the underlying causes of ill health. Here you can see what a toilet in Kailicha looked like just a few years ago. That toilet bowl was actually just standing on the sand there. There was no kind of plumbing underneath it. And as you can see, the door is coming off. So what we have to be more active about is looking at the causes of disease and the causes of the causes, the social determinants of health. And these are the kind of structural inequalities we've been talking about in this conference. Factors influencing child mortality, wealth, maternal education, whether you live in a rural area, which province you live in. You can see on this slide. This slide shows you the richest 20% of households compared with the poorest 20% of households, and their access to food. I think I've got the colours the wrong way around. I'm sorry, the colours are the wrong way around. As you'll see when you look in the hunger one, there are no rich families who have hungry children. There are very few people with inadequate water, whereas almost half have of the poorest centile have inadequate water, inadequate sanitation, living in overcrowding conditions, and then living in unhealthy conditions. They have less access to the health system. So what do we do? We have to get back to the idea of the right to health. And I'd just like to briefly go through what People's Health Movement is trying to do to link up local struggles with the global picture. South Africa has an opportunity now to re-engineer its health system through primary health care. And the question is, how do we get communities to participate and to control the process of healthcare reform that's happening in the country now? So PHM does a number of things at the global level. The first one I'll mention is the People's Health University, International People's Health University, which is a university without walls that is held in different countries at different times and trains activists from those regions about the social, the political economy of health. Here's one in Kenya a few years ago. We also produced the Global Health Watch, which I think might be circulating. Okay. Which is a critical analysis of what's happening in health around the world. The People's Health Assembly, a global assembly of activists, social movements, trade unions, and so on, that happens every 5 years. This is the one that was held in Cape Town in 2012. And what people on the stage here are all community health workers from different parts of the world, including traditional healers from our own country. No to privatization of healthcare. PHM South Africa meets with community health workers, and we feel that there's a very important role for community health workers to play in mobilizing communities around health. This is the role they played under apartheid, but that whole movement kind of became verticalized into dealing with specific diseases in a technical way as opposed to a mobilizing way. This is the South African National Health Assembly we had 2 years ago, which put together health activists from around the country to give testimonies about their own health struggles, including in the Eastern Cape. And working with unions, there's my comrade David Sanders teaching shop stewards from Nauru about health and exploring community health issues in Cape Town. So just to get back to where we need to go, the answers really have been around for many years, or the elements of the answers. principles of alliances, and they lie in the principles of primary healthcare, which is community participation. We've spoken about it in this forum. And it's amazing how when you go below the surface of virtually any struggle, you will come up at the level of the community and people's own struggles. And the real challenge is to merge all of